and then hand it over to them. So I'll start with Dr. Julie Zuniga, who's an assistant professor whose research interests include self-management of stigmatized illness in conjunction with comorbid conditions, with a focus on HIV and diabetes. Dr. Zuniga received her doctorate in nursing at the University of Texas at Austin and completed her postdoctoral fellowship at Emory University in Atlanta, Georgia. And Dr. Jae Sevelius, which rhymes with rebellious, which I really like, is associate professor in the Department of Medicine at the University of California, San Francisco, and is a licensed clinical psychologist. At the Center of Excellence for Transgender Health, Dr. Sevelius's community-led research is focused on developing and evaluating transgender-specific, trauma-informed interventions to promote health among transgender people, with an emphasis on serving transgender women of color and those affected by HIV in California and in Sao Paulo, Brazil. Dr. Sevelius's research and clinical interests lie at the intersections of social justice, sexuality, health, and identity. So thank you both so much for being here. And Julie, I'm going to hand it over to you. We'll do about 15-20 minutes for each of your presentations, and then I'm just going to give a brief overview of the HIV prevention and treatment landscape in Austin, and then open it up to questions and discussion. So Julie, are you able to share your screen? Let me know if it's difficult.
Can you see a PowerPoint?
Yes.
So thanks for having us today. I'll be presenting about, we did some focus groups with, this is very orange, some focus groups with looking to see about PrEP messaging, and we've been talking to healthcare providers and key informants and educators, a lot of different people to see what the next kind of public health messaging needs to be. And we're just kind of getting started on it. So we'll just give a little bit of what's going on and where we're going to go in the future. So describe PrEP, I'll present the methods, we'll discuss the findings, and then we'll discuss next step. I think everybody here probably knows what PrEP is. It's medical treatment that prevents HIV. PrEP is daily, and when taken appropriately, it's 99% effective. The big problem is that adherence to it. There is an extremely low adherence rate to PrEP. I can't remember the numbers off the top of my head. Maybe somebody would know better than me, but is it 30% or something that people do not consistently take PrEP. Even though when you do take it, it is very, very effective. The last numbers I looked at said there's approximately 300 people each year, new cases of HIV in the Austin area, which shows that there is a need for PrEP in the Austin area. And there has been lots of outreach, different types of outreach, wanted to see what was working. And what was not working, this was in conjunction with the Fast Track Cities. Fast Track Cities was interested in going and looking at how to get PrEP more available. So the method is focus groups conducted over teleconference, since we're in the days of coronavirus. They're stratified into 3 groups, healthcare providers, community leaders, and community members. The meetings were audio recorded and there's going to be transcribed, and the data will be analyzed using a constant comparison. We also showed the participants flyers from other cities so they can get an idea of what we're trying to look at. We're trying to see what works for them, what they like. So along with questions about PrEP, we also showed flyers like these 3 flyers from different cities to see what would work for ours. We know that each city has kind of a different culture and mood and milieu. So we wanted to show some of what we've seen in other cities and see if that what that will play here. The interesting thing is, so the top, there's like a pink one with the guy holding an HIV over his, you know, as protective. That one's from San Francisco. The one with the couple is from Chicago, and the one that has a bunch of different boxes is from the CDC. But you can see the one from the CDC is the most conservative, and everyone kind of thought of, like, there's not even 2 people close to each other in this one, so there's not, it doesn't, you know, it sends a different message than the other ones, of course, because it's from the government. So there's not, this is what we've come up with so far. So this is what we showed them, along with questions about what they know about PrEP and what they think that the values that we should base future public health messaging with. So those were some of the things that we talked about. So the findings were interesting. The thing that showed up each time we talked to people was this lot of like slut shaming, a lot of if you take PrEP you're a slut, but maybe lighthearted-ish, but it's definitely part of that. Most of the education that people got was from drug companies. They're the ones who are pushing the education and maybe be doing the education the best right now. There also is a need to focus on the unhoused population because they may not be getting the messages, or they may be needing more access than other folks. Let me see if there was any. Those were kind of the generic, overbroad, broad kind of measures for what we looked at, what came up. A lot of people did the free CEUs to be educated, are keeping up. Not very many people talked about getting reading manuscripts, but in the data that we've collected elsewhere, it does show that physicians would like journals to help them to keep educated, but this group was not much into reading anything like that. The other thing that we found that was probably the most interesting was there was a really big disconnect between depending on what your role was, if you're a provider versus like a peer educator. There was a disconnect about it was basically about condom use, that there was a couple educators who, peer educators, who said that you would not have to use condoms if you were on PrEP since you are protected from HIV, and that the STDs weren't as a high priority, and kind of freeing you from the stigma of always having to use a condom was what some people didn't like. And we ended up getting a couple different calls about making sure that we understood that that's not what PrEP was for. PrEP wasn't supposed to replace condoms. So there just seems to be, when you look at the research, it says that PrEP does not increase risky behaviors. And when we asked healthcare providers, they said the same thing, that PrEP doesn't increase risky behaviors, but there may be actually something that we're missing inside the population. People don't like to use condoms. That is completely understandable. And if you're going to use nothing, then PrEP is probably the best way to go. And if we can figure out a way to get people to use both, I think that might be what the healthcare providers are kind of focusing on, but we kind of have to match with what the population wants. So I really think that there's more to investigate here on the peer-to-peer education. So there's more to kind of delve into here. So I'm hoping that the next round of interviews is with peer educators. We also need to talk more to healthcare providers. The healthcare providers are pretty comfortable talking about PrEP and giving PrEP, but there's actually a lot of room for growth inside that there's room to grow about whether you feel that making providers more comfortable. So we think that this is definitely something we need to touch on. When we talked about how we could tailor messaging specifically for Austin, we got a lot of different things. It was, everybody here thinks they're unique, so that's one thing. Everybody's neighborhood's different. Everybody's community is different. We have a lot of, conservative and liberals and a bunch of different people who we're not going to be able to have maybe one solid message for everyone. But this idea of these microcultures inside of our community is kind of an interesting way that we may be able to reach a bunch of different communities if we think about how to do a little micro messaging to get to what people want the most. The themes that people talked about Austinites being like, and even though we're all so separate and there's not that many of us that are from Austin, is that we all want to take care of each other and that we want to make differences in our community. And a way to do this is to take PrEP as a way to take care of each other and make a difference in your community. There was a lot of discussion between how you would get this message out. Some people said that you have to have a flyer, and other people would say that you don't give out flyers because if someone saw a flyer in your pocket, that may out you on something that you are not out with. So there has to be some kind of different ways to go about it. There was this talk about making sure it's green, making sure that we're environmentally friendly. Made me think that we need to have, like, I don't know, grocery bags, even though they're legal here again, but keeping it in a way that Austinites themselves kind of think about it would be a good way to construct some messaging. There needs to be some physical takeaway for people to take home. So we need to think about that. Everyone thought that if we could get a good message out here, it would actually decrease stigma in communities that are feeling stigmatized. So if there was a wide-reaching, a broad public health messaging that our program, we might be able to reduce the stigma in people who who have HIV or feel stigmatized because of who they are, or don't feel accepted because of who they are. So if we had a good messaging, and I haven't quite figured out what that's gonna look like, that may be something that we can all talk about. But I think that it gave us a good idea of where to start from, where we can move from, and where there's going to need to be more education. We're not close to being done. I don't know about you guys, but I've been a little nihilistic the last month. So I actually need more focus group completed. If anyone's interested in helping with recruitment and doing focus groups, I would really need some motivation to get things done. Recently, we've shifted to working on a grant with Philip Schnars and with the people at Tent. And what are their other acronyms? I can't remember off the top of my head. And this one will be working at PrEP with the in gender diverse and transgender communities. This will focus instead on a short-term PrEP, long-term PrEP, which would definitely increase the adherence issue, since it's just a big problem with, let me see if I can stop sharing because that orange is just horrible. It's just the big, there's just a, see, now that I'm not orange, I can't even think anymore. So focusing on this one particular community, and because the messaging is going to need to be different for each community, and who feels seen and who doesn't feel seen. There's a group that is sometimes ignored inside PrEP, so we want to make sure that everyone who's available, who needs to get it, can get it. So we have a lot more work to be done in this area and on this project, so I'm always open for getting some stuff done, but mostly with recruitment, since I don't know if you guys are feeling the same way, but it's been very hard to kind of get going on things that I know it's that COVID-19 blues, I think. So, but we're still really wanting to get forward. We'll know, I think this month, whether we're going to go with the Merck, get the Merck funding or not, so to keep doing more focus groups and more quantitative measurement of barriers and facilitators.
Thank you, Julie. And it sounds like Mike said that he's got some folks who have done focus groups, may be able to partner with you there. Yeah. I don't know, Mike, if you wanted to say anything more about that, or.
Lexi Willie has done a bunch of stuff lately with the Dell med students and trans affirming care. So we can have a offline conversation if you'd like to set up a time. But
yeah, that'd be great.
And I know Lexi is actually presenting on that research that she's done on October 28th as part of the pop-up. So that might be a good one to attend to see kind of what she's doing and potentially collaborate. But yeah, this is exciting. I mean, it sounds like we're starting with a pretty blank slate in terms of what has already been investigated in Austin regarding these issues. So I think it's really good that we're starting these conversations. Jae, you are coming from a totally different part of the country and a different experience, I think, in terms of the amount of research that's been done. And so I'm really excited to hear from you, like what your perspective is on how to conduct this research, like your barriers and facilitators that you found, and maybe even kind of pearls of wisdom after your talk. But I'm going to hand it over to you.
Sure. See if I can go ahead and share my screen. Okay, so thank you for having me. Thank you for putting this together. It's really fun to be able to be in San Francisco and speak to folks in Austin, Texas. I happen to really love Austin. Been there many times. And I had the good fortune of working with Mike Parent on a grant last year, which was really fun to put in, and we'll continue to be working on that together. And Philip Schnars from UT Austin came and, or well, he didn't come, he Zoomed over to San Francisco and gave a really great talk earlier. So I feel like there's this San Francisco Austin thing happening that I'm really enjoying. So today I want to talk about this project that we called Triumph. We love acronyms in HIV research. So this stands for Trans Research Informed Communities United in Mobilization for the Prevention of HIV. And there will be a quiz at the end, just make sure you remember that. We had done a lot of formative research in transgender and gender diverse communities in San Francisco. We did focus groups, we did individual interviews, we interviewed healthcare providers. We looked at some of the research that was being done among MSM and really decided that there was an urgent need for trans-specific PrEP research, that we weren't getting the information we needed when people were doing studies of MSM and trying to include trans people. And we were hearing from our gender diverse communities that they really wanted very specific types of information, specific ways of receiving PrEP from their healthcare providers. So we did this community-based PrEP demonstration project for transgender communities in Oakland, California, which is just across the bay from San Francisco, and in Sacramento, California, which is about 90 minutes east of San Francisco. And we partnered, I'm from UCSF and the Center of Excellence for Transgender Health. We partnered with La Clínica de la Raza in Oakland and Gender Health Center in Sacramento. And the photo here is of two of our peer health educators and a participant who kindly agreed to be models and kind of show in our marketing materials how this really was a peer-led PrEP demonstration project. We were funded by the California HIV/AIDS Research Program, and Gilead donated free PrEP to the study. So we were able to give our participants PrEP for free. We had an incredibly large study team because we were collaborating across 3 sites. UCSF was the evaluation center and we designed the study, and then Gender Health Center had a large trans staff, same with La Clínica de la Raza, who a couple of the peer educators and the assessment coordinators were actually employed on the UCSF side, which was an interesting collaboration as well. And the great thing about our teams were that at any one time we had a minimum of 10 trans people working on the project at all levels of the project, at the PI level, at the project director levels, and at the frontline staff levels. And we were really proud of that accomplishment, really wanted to be a model for how research with trans and gender diverse communities can happen. So because trans women in particular have unique barriers and facilitators to care and high levels of medical mistrust, we really felt like this initiative, even though it was for all trans and gender diverse communities, because of the disparities in HIV that trans women experience, we really felt like the initiative should be led by and informed by the experiences of trans women of color in particular. And we really felt strongly that this should be created by the community and not adapted from MSM-focused strategies and expertise, which is typically what happens in HIV research. So the overall goal of Triumph was to develop and evaluate a culturally relevant, community-led PrEP demonstration project driven by the needs and experiences of transgender women of color. And we sought to identify the best methods to deliver PrEP safely and effectively to trans communities while also achieving the highest levels of adherence possible. Our primary aims were to develop an efficient PrEP delivery system within these two sites. One was an FQHC and one was a CBO. I'll talk a little bit more about the sites in a minute. We wanted to develop a culturally relevant and adaptive intervention to increase PrEP uptake and adherence, and then determine the feasibility, acceptability, and effectiveness of this way of delivering PrEP. So our primary outcomes were PrEP uptake, adherence, effectiveness, and persistence. We also had a few secondary aims that and one of which I'll mention briefly. As part of TRIUMPH, we conducted a sub-study to look at drug-drug interactions between hormones and PrEP, because one of the unique concerns that transgender people often have when thinking about PrEP for themselves is, will this interfere with my transition? Will there be some sort of interaction between PrEP and my hormones that especially concerns, will this slow down my transition or interfere with my gender presentation in any way? And so we wanted to conduct a study to really definitively answer that question for people. That study has been published. We found that PrEP does not interfere with hormones and that PrEP is very safe to take with hormones, both estrogen and testosterone. We looked at both. So the eligibility criteria for TRIUMPH was age 18, confirmed HIV negative with a HIV test at the first clinical visit, of course. Sex assigned at birth differs from current gender identity. So anything under the gender diverse spectrum, folks were eligible. And currently sexually active or intends to become sexually active, and an expressed desire to use PrEP. So to say a little bit about our clinical sites, Gender Health Center is this really amazing community-based organization in Sacramento that was founded by and continues to be led by transgender people and transgender women of color in leadership positions there. They've been primarily a mental health clinic, so this was the first time that they would be delivering PrEP to their clients, whereas La Clinica in Oakland was FQHC who had a strong PrEP program, but had never delivered care to transgender people. So we thought these two sites would be really interesting to compare, where one had a lot of PrEP experience, but no experience serving trans folks, and Gender Health Center, lots of experience serving trans folks, but no experience delivering PrEP. And La Clinica in particular serves Latinx communities in Oakland. And so we really focused on Latinx transgender women at that site. These were the intervention components that we really felt were critical to the success of our demonstration project. One was that we bundled PrEP and hormones together in terms of the care that people were receiving. So they didn't need to drive around the city to different providers trying to get their PrEP and another provider to try and get their hormones. We know that transgender people are very adherent when it comes to hormones. And so we thought if we could deliver PrEP by the same trusted provider, that people would be willing to come in and could ask that one provider any questions they had about the combination of those medications. Peer navigation, of course, like having transgender and gender diverse people really support, educate, and help people start taking PrEP, answer their questions, provide support. We had monthly groups where we had kind of drop-in social groups where there was some educational component, and then just general social groups as well. The clinic drop-in, we had social support and food where people could just come and hang out and be social. And then from our participants, we actually identified PrEP champions in the community. So in Oakland in particular, what was really successful was pageants that the peer navigators and the participants thought up all themselves, like were completely self-motivated to create these like PrEP pageants. They ended up being called the Miss Triunfo pageants, Triunfo, triumph in Spanish. And every year we had a pageant that was very Miss America-ish, where they would come on stage and answer questions about PrEP and then give a drag performance or any type of performance they were interested in giving. And those were outrageously successful. And then a community mobilization component. So you can see from these photo booth type photos with the women in the blue dresses, they had those dresses made in the Truvada colors specifically for PrEP events, which was really cute. And these photos were taken at Oakland Pride, where we had a booth and a DJ and photos, and all of the girls came out in their dresses. It was really fun. So this was our consort diagram. I won't go through too much of the details, but we assessed 195 folks for eligibility and enrolled 185. And then you can see that we had a 1-month clinical check-in for lab follow-ups. And then at each point, we kind of lost some folks to follow up. And we mostly lost folks, either they were no longer sexually active and not interested in PrEP anymore, they moved, they lost their mode of transportation and had been living really far away from the clinic. So we found that our folks were fairly mobile, and we had 148 reached their study endpoint at 12 months, and 63 of those made their clinical visits. 46 completed the survey after 1 year. So here you can see a little bit about the demographics and some of the differences between the Oakland and the Sacramento sites. Sorry, that first column is overall, the second column is Oakland, and the third column is Sacramento. I think that got cut off on the top there. So Oakland was significantly more likely to enroll slightly older participants, also participants who are more likely to be transgender women. Oakland was more likely to enroll Latinx participants, which was somewhat by design, and those participants were more likely to have less than a high school education. Participants in Oakland were also less financially secure. So you can see they were more likely to endorse the statement, I can barely get by on the money I have, when describing their financial situation. So we looked at PrEP uptake by the first dispensation of their PrEP bottle. So the first time they got a PrEP bottle in their hands. And interestingly, what we found was we found more rapid PrEP initiation among participants who were female sex assigned at birth. So among folks who were more on either transmasculine spectrum or non-binary spectrum female assigned at birth. Those who expressed stronger PrEP interest, which makes sense. Those who reported higher HIV risk perception also makes sense. And those who were US born. And we found slower PrEP initiation among Latinx participants and those of lower SES. Participants in Sacramento initiated PrEP more often and more rapidly than those in Oakland, and those site differences were independent of differences in participant demographics. And what we've attributed, or we really think that this is attributable to, is the fact that La Clinica as an FQHC has a very specific process for dispensing medications. And so the study drug also went through their pharmacy, where Sacramento as a CBO had fewer barriers. Literally their project coordinator could just hand participants a bottle of PrEP. There was no waiting in line. There was no going up to the third floor where the pharmacy was. So that was a big factor, in addition to the fact that, you know, having a majority Latinx community in Oakland that we were serving, there was a little more hesitance around, you know, maybe that a person doesn't have documentation and they're not really sure whether or not getting this kind of prescription is right for them. So it took them a little more time to warm up to the idea of PrEP. Then we looked at baseline characteristics that were associated with retention in the study overall. So whether a participant was enrolled in Oakland or Sacramento, did approach significance, with people in Oakland being somewhat more likely to complete the study than participants in Sacramento. So that was an interesting distinction, where folks in Sacramento took PrEP more quickly and easily, but in Oakland, they were more likely to stick with us. Age didn't predict retention, which was surprising. In other studies, they found that younger people are less likely to be retained. Trans women were more likely to complete the study than people of other gender identities. People who were US born were less likely to complete the study. And there was a trend toward those who were engaging in sex work being more likely to complete the study. Participants with a primary partner were less likely to complete the study. And interestingly, reporting condomless receptive sex at baseline did not predict retention, and neither PrEP interests nor housing status predicted retention. So we did encounter several intervention challenges, with the greatest by far being the immense need for instrumental support among our participants, both during participation and after study participation. So even once they kind of graduated from the program, they were still calling our peer navigators, needing help with things like housing, having questions about things that were going on in their lives, like really became integrated into the study in a way that they became very reliant on our peer navigators, which was great in one sense, but in another sense, it's like, we didn't really have the infrastructure around the study to always be able to meet all of the needs that our study participants had. There were a lot of no-shows and cancellations, and like I said earlier, our participants were very mobile and weren't always able to kind of stick with the study regimen of coming in every 3 months. We were somewhat able to accommodate this by rescheduling participants around their own schedule or allowing them to drop in, but this was somewhat limited because our clinician time was limited. Our clinician couldn't just be available whenever anybody showed up, but we did our best to try to have open clinic hours where people could drop in. So some of our successes were definitely the provision of trans-affirming and compassionate clinical staff at both of the sites, the increased community uptake of PrEP. Our interventions definitely fostered a sense of community, particularly at the Oakland site, which you could see in the retention data. And we did provide needed services outside of the clinic settings that were able to meet some of the participant needs besides their clinical needs, like name changes, procedures in seeking asylum. When they had to go to the hospital, our peer navigators sometimes accompanied them. So what we learned is that specifically for Latinx populations, we really saw how effective the culturally specific intervention was. So here's a photo of Pan Dulce with a Truvada pill next to it that was actually taken at one of our events, where we had culturally specific foods and culturally specific events for folks. The peer navigation was very successful. We definitely need more gender affirming providers in both Oakland and Sacramento. Fortunately, La Clinica has been able to integrate the Triumph Clinic into their existing services. So even though the research is complete, the clinic is still going on. So we were able to create a trans-specific hormone and PrEP clinic inside of an FQHC that didn't exist before. And so many of our participants are still seeing that same provider at the same clinic. So that was an overview of our study. We're currently analyzing the adherence data and getting some really interesting results and writing up the primary outcomes. But these photos were taken at Oakland Pride in 2018, and you can see like how really bonded our participants and our peer navigators were. So it was a really, really fun study. I was really proud to be a part of it.
Thank you so much. That was a wealth of information. I was taking notes about especially some of your successes and kind of the community-led events, which makes total sense. I had a couple of questions, and everybody please feel free to put questions in the chat that I can bring up or just speak up. A couple of the things that I noticed on that slide that you had about different patient characteristics or participant characteristics was two things that I thought were notable and kind of interesting as one, the very low retention if there was a history of violence. And I'm not sure what that question was, but or how that was asked, but that I think is really interesting and really critical in thinking about, you know, what we can do around kind of trauma-informed care. And I know that's very true for people living with HIV as well. And so just wondering, you know, maybe I'll stop there. I have another question, but just any insights you have about that or what that raised for y'all.
Yes, yes. Thank you for picking up on that, because I think that it was a really important finding, and we're actually finding that play out in the adherence findings as well with the drug levels, that violence, you know, higher levels of reported violence predict lower levels of drug levels across the, you know, the time frame of the study. And the way the question was asked was, you know, in the past 3 months, have you been the victim of violence? And I think we gave a little bit of a couple of examples there. I can't remember exactly, but it was past 3 months. And there were quite high levels of violence reported. And we had a couple of situations where some of our participants were the victims of violence during the course of participation. And our peer navigators actually came and met them at their house and accompanied them to the emergency room. In one case, one person hadn't started PrEP yet, and she was given PEP after a sexual assault. And so you know, I think it speaks to the need for structural interventions around anti-violence campaigns, and also the need for just, you know, just more support for, and as you mentioned, trauma-informed care, and thinking about what does a trauma-informed approach to PrEP provision in particular look like. All of our peer navigators received training in trauma-informed care, and were just incredibly compassionate and willing to be flexible with how they thought about their work. So really showing up for people outside of what any kind of prescribed job description. Even once COVID hit, that was a major barrier to our follow-ups at 12 months actually, because we had a lot of people still just right at the tail end of that 12-month survey when COVID hit. And our peer navigators actually started their own sort of collections for food and did grocery deliveries to our participants, and started an online support group so that people who were coming to the social events really regularly and really relying on that for social support had a way to connect with each other, even though the clinic was closed. And a lot of our participants needed a ton of technical assistance with Zoom. They had never been in a web-based meeting before. They didn't know what Zoom was. They needed help setting up their account and figuring out their webcam and all of these things. And our peer navigators were just incredibly patient, walking people through the process. And so I think a lot of times when you see these outcomes papers, it's really hard to capture the nuances of how much work goes into supporting the community and how important that aspect of it is to successful research, to successful clinical care. And you know, that's something that I'm hoping that we'll be able to capture when we disseminate Triumph, because it was really the backbone of the entire project.
Yeah, I think all of those points are so important, and I'm thinking about, and others feel free to chime in about this, but especially I think here in Austin, where we haven't had as much research and as much kind of community talk, I think, about these issues, at least on a clinic administration level. When we talk about setting up, you know, PrEP programs and HIV treatment programs, I think there may not be as much awareness as is needed of all of that social work that needs to go into it to actually make a difference, especially as it pertains to kind of structural racism. So yeah, thank you for bringing that up. And my other thought was it looked like also there was better adherence among Latinx participants. Do you think that was because there happened to be more peer navigator? It sounds like the clinics were a little bit more kind of centered around the kind of Latinx cultural peer navigators. And do you think it was representation amongst the peer navigators, or were there other, I mean, it's maybe hard to tease out, but.
Yeah, I do think it's hard to tease out. I mean, in Oakland, you know, I think it did have a lot to do with our peer navigators. Oakland was very focused on that culturally specific Latinx sort of experience, whereas Sacramento was more open to everyone, and their peer navigators were African American women. But it was interesting because La Clinica had already had a reputation for serving Latinx communities, and so that culturally specific intervention fit really well within La Clinica. And we thought we were gonna have to do a lot of work to get them up to speed on gender affirming care, but they were so invested that we trained all of the clinical staff and they were amazing. Everyone from like the security guards to the medical assistants. Whereas in Sacramento, you know, they already had a lot of expertise in serving trans communities, but they were somewhat known for serving white trans communities. And so making that shift to focusing on African-American women, it actually took a lot more trust building than it even did in La Clinica, where, you know, so there was something about that intersection of race and gender that played out in, you know, really nuanced ways that we didn't expect. We thought La Clinica was going to be the heavy lift, but it was actually the Gender Health Center and building bridges with communities that they hadn't been serving.
Yeah, that's a really good thing to keep in mind. So everybody feel free to keep asking questions in the chat. I'm going to be just keeping an eye on the time. I'm going to do just a brief overview, like I said I would, about the landscape in Austin, and then we'll kind of open it up for general comments. So I'm just going to share my screen and so what I'd like to do is just kind of go through some of the data available through Texas Department of Health and Human Services and our Austin specific HIV Planning Council. So this is just a map of Texas and number of new HIV diagnoses by county. And as you can see, we've got a lot of different counties, especially in East Texas, that have quite a high number of new HIV diagnoses. And in fact, when you look at the Ending the Epidemic initiative by the federal government, they've identified 57 priority counties or jurisdictions, including 48 counties. And Texas has 5 of those. So Texas has 5 of the 48 counties that make up in total over 50% of new HIV diagnoses overall in 2016 and 2017. So it's definitely relevant. And as you can see, a lot of it is spread through the Southeast, which has a lot of also overlap with many of these social determinants of health that Jae was mentioning, including limited access to Medicaid and overlapping with a lot of different policies. So just taking another look on a more granular level, the breakdown of sex assigned at birth mirrors national data on new HIV incidence and diagnoses. And I don't have here what the general population in Austin is of people who identify as Black or Hispanic, but these numbers and percentages are definitely, there is a oversized burden in terms of total population of new HIV diagnoses in people who identify as Black and Hispanic. So there are definitely some kind of racist disparities in there. In terms of age at diagnosis, we're seeing more diagnoses in younger age groups. And we're also seeing the data is not broken down very well in terms of exactly who among, say, these categories that just say heterosexual, who that really means, and modes of sex. But in general, the burden is among MSM, and when you look at prevalence compared to overall numbers of the population, it's Black and African American MSM, followed by Hispanic MSM and white MSM, and then Black cisgender women, and then transgender populations as well in Texas. We also have a problem with sexual education in Texas in terms of policies that prohibit the explicit education of sex and harm reduction. And there's some data showing that almost half of high school students in Texas have had sex and did not use condoms during sex. So there's definitely a need for other harm reduction interventions like PrEP. This is just breaking it down in terms of more of what I was saying in terms of the overall burden as compared to white people in Austin compared to Black and Latinx people. And you can definitely see there are some demographics that I think we are overlooking. So specifically Black cisgender women, there is a huge outsized disparity there. And I think they don't get a lot of attention in our conversations, and maybe partly because there's not a lot of campaigns, as Jay was saying, that are really specifically targeted to certain demographics in kind of like a culturally sensitive way. So there's a low PrEP to need ratio, especially throughout the Southeast. So among those who need PrEP, about 14% are getting it. And that's due to a lot of different systemic and social factors. So I'm just going to put this here. These are kind of the priority populations that were identified by the HIV Planning Council here in Austin. And again, I think this mirrors kind of national priority populations. But I will also point out that in these priority actually that all makes sense. And then HIV prevention needs that were identified as being kind of at the top of the list, and that research may help inform are things like Julie mentioned in her presentation: targeted social marketing, mass education to reduce stigma and to get information out there, targeted testing, routine opt-out testing, prevention with positives, condom distribution, and then sex education. So these are all things that were highlighted in their report. There are lots and lots of barriers to HIV prevention, obviously. Some of the, what I would classify as social barriers are, as Julie mentioned again, lack of perceived susceptibility to infection, so not understanding one's own, just not having the information to make informed decisions regarding HIV. Stigma, structural racism, which seems quite obvious in the numbers, in the breakdown of the numbers. Poverty, medication adherence, and anxiety around testing. I would say for structural barriers, there are a lot as it pertains to patients who are Spanish speaking or speak a different language other than English. There's a lack of educational materials, clinic staff and navigators who speak a language other than English. We need physicians and staff, social workers at every level of the healthcare system who are affirming and who are competent in terms of HIV prevention provision. I think our lack of Medicaid expansion and just the complexity of the insurance and the privatization of healthcare, especially in Austin and in Texas in general, is really, really a barrier. And I say that as somebody who prescribes PrEP. It is very difficult to navigate a patient through the process of getting PrEP. And it's kind of a duct tape system. So I think it's very easy for patients to get fed up and, not want to jump through all of the hoops that our structure imposes upon them to get the medication that they need. And then there's a high turnover of support staff because of just low funding in this field. So I would say, from what I have seen, that our research priorities should really be focused on PrEP education for providers and for clinics, and understanding better what sorts of messages and what sorts of support our unique communities need. I think that's kind of a very basic level that we have not reached yet. And then more implementation science strategies to see what works in the real world. So what are those barriers to care? What are different interventions that we can employ to try to overcome them? I think I was taking notes again on all of the things that you mentioned, Jay, in those clinics that you worked with, that they were trying to see what would resonate with the community, which different strategies and differences among clinics and how they provide PrEP seem more effective. And so I think that's going to be an iterative process and may differ where we're at, whether we're in rural Texas or here at an urban center. So I wanted to open it up to anybody and see if y'all have any other thoughts about what we might work on in the future in terms of HIV prevention in Austin, or collaboration across different sites. And I know there's some people here from the medical school, there's some people here from fast track cities.
I was just really struck by the slide where you gave the graphical representation of the disparities between Black cisgender women and white cisgender women. Like, that was really powerful to see represented that way. And, you know, just really thinking about the very unique needs that Black cisgender women who have sex with men and the unique context in which, you know, they're living their lives and sexual lives. And I'm just wondering if you might say a little bit about, you know, what is known in Austin about those unique needs and contexts.
Absolutely. Yeah, I think, again, Black cisgender women are really overlooked in terms of HIV prevention messaging. And there were so many little bodies that was probably hard to count, but it's an 18-fold difference. Huge difference between white cisgender women and Black cisgender women. And I have talked to Black women who work in the field here in Austin, who are in public health fields that work on sexual health. And what they say is that, kind of very similar to what you said, you know, none of the campaigns about PrEP or about HIV prevention in general are targeted towards Black women. And so there is a really strong message that it's not for them. So there is not an awareness that PrEP is even for women at all. There's not an awareness that they should be thinking about it. There's not an awareness on the part of providers to bring it up. So when I talk to OB-GYN doctors, who are, you know, the primary care providers for women a lot of the time, again, I'm not going to speak very much about the research that I'm doing, but let me just say that almost nobody that I talk to is prescribing PrEP. Either because they don't feel comfortable, who are OB-GYNs, they don't feel comfortable and they're not sure what the indications are. And I've talked to women who have said, like, yeah, I asked for an HIV test and they said, oh, you're only having sex with one person, like, you don't need it. But, you know, no other questions about, like, you know, there's a lot of misunderstanding about who is eligible for PrEP, I think. And so I think even on the provider side, just like not getting that it's not just MSM. And we were trying to create animated videos at the FQHC that I work at to be targeted towards different groups. And so, you know, when we were making these videos, I said, we need a video specific to Black cis women. And we were going to try to make a video for, you know, women of color. And when I went and talked to the women locally here who are in these kind of public health admin fields, they said, no, this cannot be, you know, because the video started out with just a general HIV prevention message and like, oh, let's include a Black woman. And then the message was like, no, you need one specific for Black women. And no, you can't have Black and Latina women together. Like, it has to be very, very specific. And so I'm just starting to understand, you know, that message that you said about how it has to be really directed, culturally relevant is so, so important, because people just feel like an afterthought. And if they feel like an afterthought, they're not going to engage. So, and there's a long history of a lot of other stuff going on in Austin as it relates to race, gentrification, and lots of historical and current racism. So I think there's a lot, you know, layered on that. So we're going to have to do a lot of work before we get to any sort of trust.
So interesting.
I just want to say thank you for all the work that y'all are doing, not only in Austin, but in San Francisco as well. Hearing all that information for our communities is really awesome. So I definitely appreciate, especially on behalf of Fast Track Cities Austin, what everyone is doing. Also, I just wanted to comment that not too long ago I was on a call, and it was probably within the past month, and they were talking about how there has never been a national campaign geared towards women of color, or in particular Black women. And they were talking about how they were creating that at the moment, and how it was difficult to even find a Black woman that was comfortable to do it. And they were willing to pay, the airfare and everything. And they did find a woman. So I hope that will be coming out soon on a national level, and a national campaign that we'll all start to see. But I definitely think there's an importance, to support women of color and our transgender communities, especially in Austin as well, because we have big populations of those. And then lastly, Dr. Zuniga and Norwood, if you need any help with recruiting for your upcoming calls, I'm happy to help. Since I call on all the clinics in Austin, I can, definitely reach out to either people within those clinics or community members as well. But just, again, thank you for everything that y'all are doing. This was very informative, and we really appreciate, it on behalf of Fast Track Cities. So thank y'all. Fast Track Cities. So thank y'all.
Thanks, Colt. I'll be in touch with you.
Sounds good. Thanks.
Hi,
Sounds good. Thanks.
hi, my name is Rhonda Andrew. I don't know if you guys can hear me okay.
It's breaking up a little bit.
Okay. Let me get on my. Give me just a second.
I will say one other thing as Ron is trying to get on the computer or phone, is that there's a really good program led by some of the women that I mentioned who are associated with, I think, APH, who split off and made their own program called Kiss and Tell. And it's all just kind of like small group sessions with women in the community where they just talk about sexual health, and it's like all women, it's all Black women. And the idea is just to like have open conversations, and then they'll like bring up PrEP and stuff, but it's all kind of community led. So that's one example of what I know is happening here. But again, it's kind of something that's was instituted because there was nothing else. Rhonda, did you want to say something or put in the chat?
Can you hear me better?
No. Still bringing up. I can hear you a little bit, so I may be able to translate.
No, I'll just try to call it.
Okay, and I'll put my email in here so that if you want to email me in the chat any questions afterwards, I'm happy to pass them on. Any other last questions or comments? Well, I want to be respectful of everybody's time. Thank you so much to everybody for participating in this. Rhonda, I will stay on the line, but I will formally end things since it is one, and I know that we're all have a billion Zoom calls back to back. So thank you again, and I will email y'all with the video link once it's up on our website. Thank you so much.
Thank you.
Thank y'all. Jay will be in touch soon.
Definitely.